Welcome to our highly riveting presentation on metformin today. Our case study is based on our patient Margaret, who's a 43-year-old female who leads a particularly sedentary lifestyle working as an office administrator at her local Vic Roads. She also participates in a monthly book club, which happens to be the only riveting thing about this presentation. But nonetheless, her family history is riddled with obesity, cardiovascular issues, high cholesterol, and type 2 diabetes mellitus. In the last 10 years, Margaret's been diagnosed with high cholesterol, obesity, and has begun to show signs of cardiovascular conditions. She's also more recently been diagnosed with type 2 diabetes mellitus and was informed by a local GP that she must change her dietary practices and increase her exercise levels. Subsequently, she has begun to walk 3 or 4 times a week for approximately 30 minutes. She has not experienced any prior foot issues before this. She presented to her local GP after walking with a friend just for a regular checkup, upon which a blister was identified. He proceeded to drain and dress the blister and instructed her to monitor the healing process and keep the site clean, obviously, to reduce the risk of infection. However, 3 months later, the issue intensified and the wound had developed into an ulcer on the plantar aspect of the left foot under the 5th metatarsal. Upon presentation to the podiatric clinic, we noticed that Margaret's feet were cold and that it was clear that she had the reduction in sensation in that area, which could have led to the development of the wound and the lack of severity or knowledge that Margaret thought of it. So clearly with her conditions, medication is a necessity. So basically Lipitor is a statin which is used for the management of our high cholesterol. Furosemide, is a loop diuretic for edema, and lastly, metformin, which is what we're looking at, is for diabetic management. So why metformin? Basically, metformin is being used for the management of type 2 diabetes mellitus solely. The trading name of the drug is Diabex, which is a biguanide that helps control the blood glucose levels. It is used in combination with insulin and often with other medications such as sulfonylurease, sorry for the pronunciation mistake. But one of the side effects of this is weight loss, which is quite specific to Margaret's weight issue. So when we're looking at metformin, we have to look at pharmacokinetics. So obviously we'd look at the absorption, distribution, metabolism, and excretion. So in tablet form, metformin is absorbed over 6 hours with the bioavailability of 50 to 60%. The VD ranges from 63 to 276 litres, and its main sites of concentration are the salivary glands and intestinal mucosa. Metformin is not metabolized, which is quite interesting, and the half-life is approximately 6 hours. So the pharmacodynamics is a tricky one with metformin because the mechanism of action is actually unclear. But it is thought to work via 3 mechanisms. Firstly, decreasing the hepatic glucose production by inhibiting gluconeogenesis and glycogenolysis. Secondly, improving insulin sensitivity in the muscles. And lastly, delaying intestinal glucose absorption. Metformin acts on glycogen synthase to stimulate intracellular glycogen synthesis. It also increases the transport capacity of all types of membrane glucose transporters. Important drug interactions are can be easily related to Margaret just because of the number of drugs she's taking and her behaviours. So her excessive intake of alcohol may increase the risk of hypoglycemia. The use of loop diuretics may increase the risk of lactic acidosis because of their potential to cause decreased renal functioning. Metformin shouldn't also be used with heart failure when conditions such as heart failure are present or potential cardiovascular issues. except in special circumstances. So basically, this is a special circumstance, or it's been overlooked by one of Margaret's treating practitioners. Given that there are potential detrimental drug interactions, but it may also be suggested that Margaret is referred for counselling to emphasise the risk of her behaviours, or poor behaviours at that. So, the outcomes for the use of metformin has allowed Margaret to more effectively manage her diabetes. She's also lost a staggering 12 kilograms with the use of metformin, or the therapy, not just purely on that. It's obviously a two-way street with the exercise as well. However, there is a reason for some concern, as some of her behaviours suggest that she may not consider the significance or severity of these conditions, especially with the continued use and abuse of alcohol. So, continuation of such behaviours could lead to serious complications if not managed correctly. Further to this, it appears that the drug interactions have not been carefully considered by Margaret's physician, and there is potential for this to cause serious issues. Overall, the effectiveness of metformin has been positive, and there is a scope for greater improvement in counselling and further podiatric intervention, which luckily enough gives us podiatrists a job. So that's basically the end of our discussion as such, our formal proceedings. So if you're more than welcome to ask a few questions, and you're also welcome not to ask any questions. Thank you.